introduce yourself. Thank you very much.
So, a very good afternoon to one and all. As sir said, I am Dr. Ajinkya Pawar. I am an endodontist by profession. I come from India where diversity is at par, and every one of us greet everyone we meet by saying namaste. So here I say once again namaste to one and all. Here I would like to show you one video which was made by a famous stand-up comedian, that was Mr. Rajiv Satyal, who describes India in this 1 minute. So please bear with this video, and it's just for entertainment purpose and nothing to get offended.
I'm Indian, just Indian. I'm not South Asian any more than Russians are North Asian. I'm not Asian Indian or East Indian. There are 1.3 billion of us. We don't need a cardinal direction, okay? It's not our fault that Christopher Columbus got lost. Sure, we love our states, but there's strength in numbers. 1 out of every 6 human beings is Indian, so stop dividing us. The British already did that once. And we need to quit saying that we're not Indian because I wasn't born here, or sound like this, or eat that. Our hearts are Indian. We're feelers. We gave the world the romance of Bollywood films and the music of Ravi Shankar and Zubin Mehta and Lata Mangeshkar and Asha Bhosle and the allure of the Kama Sutra. We are thinkers. We are great at math because we invented numbers. And we're pretty good at letters, too. We are doctors and engineers and techies. And we mean business. We're the world's 3rd largest economy and the wealthiest ethnic group in America. We are huge and efficient. India is all on one time zone. That way everybody in the country is still late, but at the same time. We never invade anyone because we already have everything. Chess, the ruler, the button, wireless communication, arranged marriage, flush toilets, steel, democracy. All us, all India. And you're welcome, world, for yoga and elevating cricket into a multi-billion-dollar sport and making food so good that you sailed across the planet to come have some. Our food is hot. Our country is hot. Our women are hot. Our men are lucky. Where the world prays, we meditate. We practically invented religious tolerance, and we gave you Mahatma Gandhi and pundits and gurus and karma and dharma and kismet and reincarnation. The motherland is magical and mystical, and no matter who you are, you can find yourself here in incredible India. Jai Hind. I am Indian.
So thank you all for listening to this short video. So I come from this university which is in Pune, that is in the state of Maharashtra in India. That is the D.Y. Patil Dental School. This is my title, which states that striving towards perfection with the self-adjusting file. Now this self-adjusting file is a new concept in endodontics, which is a hollow file and adapts itself to the root canal shape and enlarges, maintaining the original shape of the root canal. So coming on to something known as a comfort zone, everyone present here are happy with the endodontic treatment they are providing, or for that fact, any other treatment that you are providing to your dentist, to your patients comfortably. This is your comfort zone. You can see here in one of the bowls there are many fishes which are present in that bowl, and that is the comfort zone. So like you all, there are many people around you who are at the same comfort zone. But another fish who takes a leap outside the comfort zone fetches a place into another bowl where it is alone, which depicts its uniqueness. So here I would request you all to kindly keep your minds free of your comfort zone in order to understand this file system, and then you decide whether you want to take a leap or no. So the research which we'll be discussing today is the current technologies and the new concept of 3D adaptive endodontics. Here I'll be presenting for 4 to 5 researches of mine which have already been published or under preparation, or which have been submitted to the various journals, which shows the advantageous behavior of the self-adjusting file over the currently used rotary or reciprocating files. So as we all know that the holy trinity of endodontics is gaining a straight line access to all the root canals which are present inside the tooth being treated, followed by successful shaping and cleaning, and then obtaining a fluid tight 3-dimensional seal with a biocompatible obturating material, all of which leads to healing of the treated tooth. Now conventionally there were hand files which were introduced for instrumenting the root canals. They have some inherent disadvantages that they are time consuming, they are less flexible, they extrude more debris periapically, and they also lead to canal transportation. The introduction of rotary and then reciprocating files followed this. This introduction changed our concept of endodontic treatment from conventional to contemporary endodontics. It proved as a great technology as it provided motorized instrumentation, faster instrumentation, and also ability to negotiate canal curvatures. Nevertheless, the rotaries will always remain rotaries, or for that fact reciprocating files which use reciprocating motion recently introduced like wave 1 or reciproc. You will come to know why I made this statement that the rotaries will always remain rotaries in due course of this presentation. Now there is a common misconception between all dentists or endodontists that all root canals that they treat are circular in cross section. But here for an example, if we take a cross section of a lower mandibular molar, and you can see that the mesial roots or the distal roots, they are not circular but they are oval or they might be tear shaped. This is a classic example which was done by Frank Puckey using microcity to show the complexity of the root canals which were present in the mandibular molars, and you can find not a single root canal in the mandibular molars is circular, and all are having various shapes which are present. So for that fact, if we take for an example the schematic diagram of a oval shaped root canal and you instrument it with a rotary file, you can see how the rotary file instruments leaving around more than 50% of the areas untouched. So what does a rotary file do? The rotary file imposes a circular bore on every canal with any cross section. So this also, it does not address to the three-dimensional shape of the root canal. As you can see here in the CBCT scans of a maxilla or a mandible, you can see that not all root canals are circular. For the mandible, you can see the teeth ranging from incisors, canines, premolars, distal roots of mandibular molars, all have oval cross section. Also for the maxilla, you can see that the canine and the second premolar have oval. Again, when you use a rotary file for this, it will prepare a circular bore. This was another study which was done by Professor Metzger, and he uses micro-CT again for seeing the shaping ability of the rotary files in oval shaped root canals. You can see 2 mm from the apex. The root canal instrumentation is adequate, and the yellow one is the after preparation and red one is before preparation. But the fact comes when you see the sections which are taken 4 mm and 6 mm above the apex, and you can see the effect of rotary preparation on irregularly shaped root canals, leaving most of the root canals untreated. There was another study which was done by Frank Puckey, which sir quoted just now. This was the study where he used in distal roots of mandibular molars, he used pro-taper rotary files according to manufacturer's instructions, and stated that it left more than 80% of the, almost 80% of the areas untreated. Then they used the pro-taper files with circumferential filing and also found that the percentage was reduced, but almost 70% area again was left untreated. Then the reciprocating files were used to instrument the oval canals, and you can see in this histological section how the reciprocating file also has created a circular bore. This is known as a keyhole preparation, where the canal recesses have been packed with debris and also leaving areas untouched. This led to the evolution of three-dimensional adaptive endodontics. This is the self-adjusting file. You can see that it is hollow and it gets compressed and adapts to the root canal shape. As I said, self-adjusting file is a hollow, elastic compressible file which is made up of nickel titanium lattice. They are available in 2 diameters, that is 1.5 mm and 2 mm diameters, and a standard length of 21, 25 and 31 mm. It is not a rotary file, it is not a reciprocating file. It is to be used with transline in and out motion. It is, you can say that it is a vibratory file, and it is to be used with 5,000 vibrations per minute. Now this is the RDT3 head and this is the RDT3 NX. These handpiece heads can be attached to the currently used rotary or reciprocating endomotors like XMart or XMart Plus, which will convert their rotary or reciprocating motion into vibratory motion. Now, as this file is hollow, through its lumen, there is a continuous irrigation which can be applied during the shaping procedure. Now, this is the Vetia pump which comes with the starter kit of the self-adjusting file, which provides continuous irrigation during the instrumentation. So, we carried out one study to compare the centering ability of We carried out a study to compare canal centering ability after instrumenting oval canals with self-adjusting file, rotary file and reciprocating files using CBCT. You can see that the red one is pre-operative and the blue one is after instrumentation. You can see how the rotary or the reciprocating files failed to reach the canal recesses. These files, they prepared the root canal well-centered mesiodistally, but buccolingually they could not reach the lingual recesses. Whereas the self-adjusting file, as it got compressed inside the root canal, it addressed to the entire root canal surface. These were the results of those study. You can see that AB is the buccolingual dimension and CD is the mesiodistal dimension. The rotary and the reciprocating files failed to reach the buccolingual recesses both in coronal and the middle third, whereas in the apical third these files were comparatively effective, as we know that most of the root canals in the apical third are circular in cross section. Now, as I said, this is the first and the only file which adapts to the root canal shape. That is the reason why in oval canals or irregularly shaped root canal, it addresses to the root canal surfaces. You can see here in one of the X-ray this file is compressed, whereas in the other X-ray it is elongated and it is adapting to the root canal surface. You can see here by a video how when the file is been inserted into a clear acrylic block, it gets compressed, thus adapting to the shape of the unprepared acrylic block. Now, how much does this file get compressed? As you can see, there are two X-rays. This is a 1.5 mm file and this is a root canal which has been prepared by a 20 number K file that snugly fits till the apex. And this is the self-adjusting file which gets compressed to a 20 number K file. When it gets compressed to a 20 number K file, you can see the elongation, how much it gets and how it can adapt to the radicular surface. Now, when you are treating irregularly shaped root canals, you have to over-instrument them using larger files in order to accommodate all the areas of the root canal. And when you obturate them, you can still see that the areas are remaining untouched and the remaining dentine wall thickness. So, using larger sizes files, they cause micro cracks into the radicular dentine. Now, why micro cracks are formed? You can see there was one study done by Kim et al. And reported in Journal of Endodontics. The stress generated by the rotary or the reciprocating files onto the radicular dentine. And you can see the stress range from 300 to almost 400 megapascals. We all know that the dentine tensile strength is 106 MPa. So, this is the reason why the rotary or reciprocating files cause micro cracks into the radicular dentine. They used the self-adjusting file and stated that the self-adjusting file generated a minimal reaction force and resulted in minimal dentine removal. This could attribute to the reduction of fracture risk and dentinal defects. Here you can see by the video, when the self-adjusting file is used for instrumentation, the stress which are generated onto the radicular dentine, and this is just the apical third which they have shown, and you can see the entire area which is in green zone which is acceptable. So we did one study to see the micro cracks which are formed after instrumenting root canals using ProTaper, Wave 1 and SAF. This study was done in conjunction with the Tel Aviv University in Israel, and you can see that the ProTaper file resulted in forming 40% of the samples with with micro cracks into the radicular dentine. Wave 1 resulted in 30%, whereas the self-adjusting file resulted in 0. Till date, whichever studies have been reported on micro cracks into the radicular dentine, SAF has been reported to have 0% of micro cracks. Now, when there are micro cracks into the radicular dentine, the fracture resistance of the tooth also reduces. When there are micro cracks, you obturate the root canal with lateral condensation. The spreader also generates some stresses onto the tooth. So we formulated one study to see the fracture resistance after instrumenting root canals by 2 rotary, 2 reciprocating, and versus the self-adjusting file. And these were the results which we found. Compared to the control, the rotaries and the reciprocating files, they showed a significant difference in reducing the fracture resistance, whereas the self-adjusting file showed no significant difference when compared to the control. The reciprocating file reduced the fracture resistance by 29 and 27%, and the pro taper files reduced by around 17 to 20%. Now, when you are instrumenting a root canal, there is active packing of the debris into the canal isthmuses or pushing the debris beyond. So here how the root canal isthmuses or irregularities have been packed by debris is demonstrated by this video. This video you can see it is by Ruddle, who is the inventor or who developed the pro taper files, and you can see how the canal recesses are being packed by the debris when you use rotary files for instrumentation. Also, when you are instrumenting in a clear acrylic block, this also demonstrates how the lateral canals have been packed by the debris during root canal instrumentation. So Frank Paquet again carried out one study using micro-CT to see the amount of debris which have been packed into the canal, into the isthmuses of the canal. Now he took mesial roots of mandibular molars where the isthmuses were present from the middle third to the apical third, and after pro taper instrumentation he found that 10.1% of the debris were packed, whereas with the SAF it was 1.7% of debris packed into the isthmuses. Again, I am not saying that it is the best, but 1.7% is 100% better than packing 10% of the debris into the isthmuses. Then if not the isthmuses, they are pushed periapically and lead to apical extrusion. So we recently published one research to compare the apical extrusion of debris using rotary, reciprocating, and the SAF. You can see here the SAF instrumentation, which is associated with continuous irrigation, also extruded least amount of debris periapically when compared to the rotary and reciprocating files. The wave 1 reciprocating file extruded highest amount of debris periapically. Also, during a retreatment study, the SAF was associated with only 12% of extrusion periapically. Now, why there is extrusion of debris? As I said that this file does not have cutting flutes or blades which does not cut the dentine. Instead, it has an abrasive surface. It abrades the radicular dentine and does not cut. That is the reason a dentine dust is formed inside the root canal, which is easily removed by the continuous root canal irrigation. Also, why there is no extrusion of debris periapically can be seen by this video. You can see that they have over-instrumented the root canal. They have over-instrumented the root canal, and after that they have used a self-adjusting file where you can see that also with continuous irrigation, it does not extrude any drop of irrigant beyond the apex. This is instrumenting the root canal. Also, when you use a needle and syringe irrigation for such cases, it demonstrated extrusion of the irrigant. You can see here how when you are irrigating, the extrusion of the sodium hypochlorite, which we usually use, happens during while we use a needle and syringe irrigation. As I said earlier that this file has a sandpaper effect. When we have to repaint our houses, we use sandpaper to remove the prior color. So when we use it on the walls, it does not cut the wall, it removes dust of that paper dust of that color, and you can easily mop it out, so it does not create chunks. This also creates a dentine dust. With the irrigation, the debris are augured away from the to the coronal third. Now, when these canal isthmuses are packed with debris or canal recesses are packed with debris, The ultrasonic irrigation also cannot remove this packed debris, which has been reported by Dedeus in Journal of Endodontics. So when the canal irregularities have been packed with debris, the obturation is impaired. Even when you use a thermoplastic gutta percha to obturate, if there is presence of debris into the canal irregularities, it cannot flow. So there was one study which was done by Dedeus, again reported in paired oval canals. He instrumented one with rotary pro taper, the other with the SF. You can see here that the canal recesses are packed with debris, and they used a carrier-based thermoplastic obturation which failed to reach the canal recesses. And this is what they got after instrumenting the root canals with the self-adjusting file. Now when there is packing of debris inside the root canal and the obturating material is not in intimate contact with the radicular dentine, the bond strength of the root canal filling also decreases. So we recently published one research article in International Endodontic Journal to see two different obturating materials. One was the novel C point used with combination with Brasseler's endosequence bioceramic sealer, and the other was gutta percha and AH+. So when oval canals were instrumented and obturated with gutta percha and AH+, this is a conventional, for that fact, conventional combination with the novel combination, that is wave 1, instrumentation, gutta percha and AH+ obturation, and self-adjusting file instrumentation, and C point plus BC sealer obturation. Now this newer combination increased the push-out bond strength in the apical third by 80% and in the coronal third by 38%. For that fact, if we compare the same obturating system with either wave 1 or SF instrumentation, it still showed a significant difference between the two groups, and self-adjusting file instrumentation was associated with higher push-out bond strength of the root canal filling. Now, effectiveness of retreatment files in removing gutta percha. Now, there was a study which was reported that the retreatment files left 35% of the root canal fillings inside the root canal after using them sequentially. So we currently carried out one study to see the removal, whether self-adjusting file can increase the removal of the root canal filling residues left after the retreatment files. So this was the obturation. This was after retreatment files, which left 26% of the previous root canal fillings. And this was with the self-adjusting file, which left just 7% inside the root canal dentine. So to conclude, we cannot guarantee success, but we should spare no effort to deserve it. Thank you so much.